Welcome to day 3 of our Boot Camp Series 2025. My name is Amy Rich, and we're going to go over the topic of healthcare provider reimbursement on day 3 of our Boot Camp Series. We're taking you through this obstacle course, and we are now at the point to get to the ring challenge. And we hope that if you've sent a complete bill to the insurance carrier, it's going to ring true that the carrier is going to reimburse you. So we're going to go over reimbursement. Your learning objectives today is to learn how to calculate professional reimbursement. Professional reimbursement is not an ambulatory surgery center bill. It's not a hospital bill. It is from the professional, the healthcare practitioner themselves. That is professional reimbursement. That's what we're going over today in this video. Now, we base our reimbursement on the Medicare guidelines for the most part, but there are some notable exceptions to the Medicare payment policies. We'll go over some of those today. And understanding the billing for workers' compensation specific services like functional capacity evaluations. We'll review a little bit of that also. So let's get started in healthcare provider professional reimbursement 2025. Our disclaimer is always that the purpose of this video today is to educate system participants. But you all have a responsibility to know the statute, which is also the law or the act, both of them, the Texas Insurance Code, the Texas Labor Code, and the rules, which are also called the Texas Administrative Code. Because if there's ever a dispute or discrepancy, the rule language and the language of the law will always supersede any opinions expressed by the speakers in these videos. An overview of what we're covering today. First, Chapter 134. We've had previous videos that talk about the billing rules and deadlines. That's all in Chapter 133. If you want to learn about reimbursement, you're going to go to Chapter 134. That's all about the charges and payments in workers' compensation. Specifically, we'll go over the medical fee guideline for professional services. That's the majority of the medical bills or claims, if you would call them, in our system come from professional services. We'll have some reimbursement calculation examples. We'll learn about fair and reasonable reimbursement. We'll learn about the workers' comp specific services and some miscellaneous reimbursement, all covered in today's video. So Chapter 134 is comprised of these subchapters, and that is subchapter A is medical reimbursement policies, B, miscellaneous reimbursement, C, medical fee guidelines. This is where you're going to find the actual rule language for the medical fee guidelines. If you're a hospital out there or a facility, the health facility fees are found in subchapter E. And also pharmacy reimbursement and pharmaceutical benefits are all found in subchapter F. So that comprises of all of chapter 134. So the applicability, this is, well, what does chapter 134 apply to? They apply to non-network healthcare. So if your doctor or your healthcare practitioner has a contract with the carrier network, these reimbursement rules usually, for the most part, do not apply. Your contract outlines the reimbursement for healthcare services provided to a network claimant if your doctor or healthcare practitioner is in the network. This includes political subdivisions. Sometimes they're called 504s because that's the section of the law that outlines political subdivisions. They can operate like networks. That means you have a contract with them, or they can direct contract. Again, another contract. This will outline your reimbursement. So that is excluded from our fee guidelines. So basically, these fee guidelines do not apply to certified workers' compensation network or political subdivisions that operate like a network or have a direct contract, except for the following exceptions. For designated doctor, required medical exams, or treating doctor impairment rating exams, those fall to the fee guidelines outlined in Chapter 134. So the discounts do not apply to designated doctor exams, required medical exam doctors, and treating doctor impairment rating exams. So no discounts, no contract will supersede what our fee guidelines say there. Medical exams for supplemental income benefits, where the treating doctor examines for compensable injury, doesn't happen very often, if at all, in this system, but that is an exception. Out of network healthcare provider approved by the network. So if your doctor is seeing a network claimant, but you don't have a contract with that network, but your doctor's gotten special out of network permission to see that claimant, then our fee guidelines would apply. Also, in the event of an emergency and the network claimant goes to an emergency room, our fee guidelines would apply. So for out of network healthcare approved by the network, or in an emergency, if that healthcare provider doesn't have a contract, our fee guidelines will apply. So also, if an injured employee doesn't live in the service area of that network, then our fee guidelines could apply there. And also, pharmacy is carved out of network operations. So the certified workers' compensation networks, that contract will not include reimbursement for pharmacy. Our pharmacy fee guideline will apply. So those are the exceptions. So for workers' compensation non-network, that's about 50% of all injuries fall in the non-network. That means that employer that insured that employee did not choose to buy a policy that's part of a network. So 50% of injuries these days are non-network, and you don't have a contract with them. So in that case, the maximum allowable reimbursement, or the MAR, is the maximum allowable amount that the fee guidelines say in the absence of any contract. Has to be consistent with 413.011 in our rules, the fee guidelines. So that's the MAR, is what are you going to get paid for the non-network reimbursement. So reimbursement for non-network healthcare is, what does the fee guideline say? Or do you have a contracted or negotiated contract? And if none of the above exists, then a fair and reasonable amount. And we'll get into more detail about fair and reasonable. So that's your step down. Do you have a fee guideline that applies to your service? Yes, then use that amount. Or do you have a contract? And if not, then it's fair and reasonable. So when you're talking about fair and reasonable, there is some language in our act, the Texas Labor Code 413.011, that gives you the criteria of what is fair and reasonable. All our fee guidelines should meet this criteria outlined in the statute, but also if you have a service that has no value by any fee guideline and you don't have a contract, then these are the criteria for the reimbursement. One, the payment ensures the quality of medical care. So you're paying enough for you to have quality medical care offered to the injured employee, but it achieves effective medical cost control. So it's not out of control. It is ensuring the quality, but not paying too much. And the payment does not pay for a fee in excess of a fee charge for similar treatment for a person that has a similar equivalent standard of living. So that's what the statute says. That's what the Texas legislature says is fair and reasonable reimbursement according to the law. So let's go into 134.203. Again, this is the subchapter C, medical fee guidelines. The majority of the medical bills that are processed in the workers' comp system are professional medical bills. So we're going to go over 134.203. And just a note, if you were to navigate to chapter 134 on our website, you'll see an old fee guideline. That old fee guideline 134.202 does not apply. And you can see that in the first few sentences. Every fee guideline will have an applicability section at the very beginning of the rule language. And for 134.203, it's going to tell you that it applies to dates of service on or after March 1st, 2008. So that's how you know it applies to you. So don't get confused by the older fee guideline in that chapter. It's 134.203 for professional services. Now, there is an exception, of course. We always have these little caveats. Workers' comp specific code services and programs are in other fee guidelines, which we'll go over some of those today. Prescription drugs or medicine is covered by the pharmaceutical fee guideline. We also have a dental fee guideline, and those services that are basically follow a contract through a network. So 134.203 applies to all the rest. The 134.203 has these major categories in it, and it goes over the reimbursement for evaluation and management, your office visits, general medicine, PM&R, physical medicine and rehab, that's your physical therapy, occupational therapy, speech therapy. Also, radiology is covered in this, durable medical equipment, laboratory and pathology is covered by 134.203. Anesthesia is also part of this. Surgery, while you're conducting surgery in your office, or if your patient goes to a facility, your healthcare provider's bill are the professional services related to that surgery performed in the facility, all covered by 134.203. And that rule, 134.203, says that for coding, billing, reporting, and reimbursement of professional medical services, the following apply. And that is all the Medicare payment policies with few exceptions. So Medicare coding, if you don't know how to find the Medicare information, that's a good thing to know if you're going to be billing in workers' comp, because we follow most of the Medicare policies. So if Medicare says use this CPT code over this one, then you need to follow that instruction. So Medicare coding, billing, NCCI edits, which are National Correct Coding Initiative edits. Medicare's website, cms.gov, has the NCCI edits. Most of you have practice management software that applies the NCCI edits to your bill, but those apply. Any modifiers that Medicare requires you to use, the health professionals shortage areas, physician scarcity areas, also HIPSAs and PSAs apply to us, and other payment policies on the effect on the date of service. So people call us all the time at Comp Connection and say, does this Medicare payment policy apply? Basically, it's all Medicare all the time unless we say differently. We also have where Medicare doesn't cover and pay a shortage area bonus, we have an incentive payment of 10% added to the MAR for services provided in our designated underserved areas. You can find those zip codes in 134.2. So if a HIPSA is covering you and you're getting a bonus payments through Medicare, you're not going to get another 10%. But for those zip codes that are not covered by Medicare, and in this zip code, you're going to get your 10% extra. We want to make sure that our engine employees are getting services in the rural areas also. Also, so any exceptions to the Medicare policies by DWC rules, our rules and laws will supersede any conflicting Medicare payment policies. But generally speaking, you should probably move your Medicare biller next to your workers' comp biller because we're going to basically follow the Medicare payment policies for coding and reporting, all of those things. Some notable exceptions to Medicare payment policies because our statute and laws and rules say differently than Medicare or conflict, ours will always supersede. Just take chiropractors, for instance. In the Medicare system, there are limitations to what a chiropractor can provide. Not in our system because of 413011C. We don't restrict chiropractors' ability to provide services within their scope and practice. Now, if they're going beyond their scope and practice, that's a license problem, and they shouldn't be doing that. They should stay within their course and scope of their practice and their licensure. But if, say, Medicare says you can only do manipulations for correction of subluxation, we say a chiropractor can provide all the things within his or her purview as their license. So that's a big adjustment, if you will, to our all Medicare all the time. Chiropractors can practice within their course and scope. Now, Medicare payment policy changes all the time. So they have a lot of programmers up at Novitas to change when Medicare makes changes. So sometimes Medicare might occasionally, or maybe rarely, try to make something retroactive. We don't do that in our system. We have hundreds of carriers. So basically, as Medicare changes, as soon as they announce it, and they have their effective date, that'll be that day forward for our system. We're not going to go backwards. So if they go back 3 months, we're going to start on the day they announce that change. So just know that we're not going to do any retrospective policy application. But if Medicare changes, we change also. just no retrospective application. So here are some examples of the Medicare payment policies that apply. These are ones that we get calls on and ask, does this apply? Does this apply? We're saying yes, all Medicare all the time, unless there's a conflict. And then ours will supersede. Let me give you some examples. There is a policy with Medicare on multiple procedure payment reduction, MPPR, for select therapy services like physical therapy, occupational therapy, surgery services, and other applicable services. So this is an example of Medicare payment policies that do apply, MPPR. And a note here. So for chiropractors, they're going to provide physical medicine charges. The MPPR policies would apply to them too, just like any other physical therapist. The Medicare National Correct Coding Initiative, or sometimes called procedure to procedure edits, to determine the use of the 59 modifier. All of those payment policies that Medicare uses on code pairs apply in our system. And their instruction on how and when 59 modifier is used applies in our system too. There's also functional reporting modifiers, GN, GO, GP for therapy services, CQ, CO for physical therapy assistance and occupational assistance. All of those are required in our system. And there are many other Medicare payment policies in general. Most of them apply. If you have questions, you can always call Comp Connection. Now, the ones that I've listed, if Medicare changed tomorrow, we would change too. So even though I've got it in this slide, if it changes, Medicare changes, we're on that moving train as Medicare changes. So some conflicting payment policies where Medicare says one thing, we say another, ours are going to take precedence. Some examples are 408.021 is our labor code that talks about an injured employee's entitlement to medical benefits. It says that our injured employees are going to get all health care that's medically necessary for the compensable injury. Now, in Medicare, there are some limitations. They have some monetary caps, say on PT, there's an X amount of dollars that they'll reimburse a year for a Medicare recipient. Because of 408021, we're not going to have a monetary cap on the number of physical therapy reimbursements. Our injured employees can get all that's medically necessary for the compensable injury. So those caps won't apply. There's also something called the medically unlikely edits, MUEs, on the Medicare side. And they have some policies that say, we don't think that more than 5 of these units will ever be necessary for our Medicare patients. So that's like a cap on the number of units. We don't have those because of 408.021. Again, your services have to be medically necessary for the compensable injury. There's no cap on only, 3 of these or 5 of those or whatever in general. FCEs are an exception. We'll talk about that later. Also, the second example I'm going to give you about conflicting Medicare versus workers' comp policies, licensed healthcare practitioners must submit their own bills due to 133.20, medical bill submission by healthcare provider. Well, that conflicts with the incident to policies that Medicare has. If you know Medicare, they're going to allow, after the first visit by a doctor, they're going to allow, say, a mid-level PA or APRN to bill under that doctor's license number. We don't allow that. If you are licensed, not certified, licensed as a healthcare provider in Texas, and you treat workers' comp patients, you have to submit your own bill under your own license number. So again, this is a major conflict. Ours will supersede. Also, we're going to go over in depth non-physician practitioner, like physician associates or PAs and APRNs. We have a loop to the insurance code in our statute, 1451.104. It talks about non-discriminatory payment or reimbursement to non-physician practitioners. And this is in conflict with Medicare's lesser of reimbursement for PAs and APRNs. We'll go over that in detail soon. But this is another conflict. Ours are going to supersede. So the correct billing codes. You are responsible for using the most current level 1, which are also called CPT codes, and level 2, which are like the alphanumeric HCPCS codes. Use the most current. So if we're in 2025, you should be using 2025 codes, and that goes for ICD-10 codes. Those are the diagnosis codes. Use the most current level. So if your coder, your charge master person needs to be using current CPT and HCPCS codes for that date of service. Now, there are some codes listed in our workers' comp specific fee guidelines. We're going to go over there and talk about that later in this video. Know that there are some exceptions in there. We have some case management codes in our workers' comp specific fee guidelines in 134.220. Those case management codes, the AMA and CMS deleted them. So they're no longer active. You won't find them in the 2025 CPT code book, but we keep them alive because we name them in our rule. So pay attention to that. Again, another conflict that ours supersedes for case management codes. But generally speaking, use the current HCPCS, CPT, ICD-10 codes. So for your evaluation and management services, these are your office visits. Your doctors and your coding staff are going to be making selections on your E&M services based on one of two criteria. That is medical decision making, MDM, is one way you can select a 99213 or 214, 215. That is one way you can select the appropriate CPT code for an office visit, or you can base it off total time. This is all outlined in CMS policy. I've given you a couple links to look at those CPT codes, descriptors. So you need to read the descriptor and then decide if you're picking your CPT code based on medical decision making or the time spent with that patient. So just know that if you bill a code to the carrier and they deny because documentation doesn't support your selection, if you're going to change that CPT code, you need to do it within 95 days from the date of service. It could be looked at as a whole nother bill if you try to bill it after 95 days with a new CPT code. So be careful selecting your E&M codes and make sure your documentation supports either MDM or time spent with the patient. Examples of reimbursement calculations coming out of 134.203. You're going to apply the Medicare payment policies with a DWC modification. I will explain to you for the following professional service categories. E&M, evaluation and management, those are office visits, general medicine, PM&R, which is physical medicine rehab, radiology, pathology, anesthesia, surgery while your patient's in the office, or your bill associated with your patient being in a facility. This is the calculation that Medicare uses. If you're familiar with the RBRVS system, Medicare has a very sophisticated way of valuing your payments coming from Medicare. We're going to take that calculation and use it in workers' compensation with an adjustment, a change. So they're looking at your work expense according to your work GPSI, which is Geographical Practice Cost Index. That's just basically where you are in the state of Texas. So they're adjusting it for your area. They're taking your practice expense and then against the GPSI and the malpractice expense against your GPSI for your location in Texas. So it varies across Texas. We're a large state. That equals your total RVU, relative value unit, and then Medicare comes up with a conversion factor every year, and that equals your Medicare amount. So that's Medicare's reimbursement for you if you're billing Medicare, but you're not for workers' comp. This is workers' comp. I just wanted to show you this calculation that Medicare uses because we adopt it, except for we replace the Medicare conversion factor with our conversion factors. We have two of them. And you can find them on our website. I'll show you a picture of them in just a minute. Our conversion factors change every year. So we're going to announce it in the fall and we're going to publish it in January. And it's based off the Medicare Economic Index, basically the cost of goods and services that are published by Medicare every year. We base our conversion factors off of that. So Medicare has a different conversion factor. Ours are ever since we came up with conversion factors, ours are greater than the Medicare conversion factor, and it reflects the changes each year. So for 2025, if you went to C on our A through Z and went to C for conversion factors, you're going to see this table. I just grabbed the screenshot here. And for each category that I talked about earlier that's covered by this professional fee guideline is listed here. So the top row is for 2025 through, well, January through December of 2025. And then you'll see the previous years listed there. And we'll drop off as we keep going through other years. But your conversion factors for DWC are $70.18, which equals 217% of what Medicare pays. So that's for anesthesia, evaluation and management, general medicine, pathology, PM&R, radiology, surgery in an office, surgery in a facility is different. It is $88.10. And that is 272% of Medicare. So for those first categories, you're getting 217% of what Medicare would pay you for that part of the state. And then for surgery while your patient's in a facility, you're going to get 272% of Medicare. And you see the last column, that is the percent increase year over year. So from last year to this year, we went up 3.5%. So you are getting raises in our workers' comp reimbursement. And that's all good news. The year before, we had a 4.6% increase. Again, it's based on the MEI. So we use Medicare, but we replace the conversion factor. Let me show you what it looks like. So remember that calculation? That's the calculation I've been talking about. The work with the gypsy, the practice expense, the malpractice expense, that gets your RVU and on the left side, and then Medicare multiplies it times their conversion factor, which is like $32. It'll come up on upcoming slides. But on our side, for workers' comp, you're going to use the same calculation, but you're going to use our conversion factor. That's the modification. So again, we base it on Medicare unless we say different. And in this case, we use our DWC conversion factors, either the first one, $70 or the $88. That's our maximum allowable reimbursement. So I took a long calculation example comparing Medicare to our reimbursement, 99214 for Austin, Texas in 2025. I took the actual numbers off the Novitas website. You can find them. In fact, I might show them to you right now. I got all these numbers. If you want to do the long calculation, it is the most accurate. But you see, we replaced their $32.34 with ours. So you see the difference in what Medicare would pay you for 99214 for what there. And I'm going to bring over the website for a second and show you how I got those numbers. For those of you that create spreadsheets and such, I'm going to go to Novitas, which is our Medicare administrative contractor. This is where you're going to find what Medicare pays for jurisdiction JH, which is Texas. You see our picture there. And then in here is the fee schedules. See, it's a picture of a calculator. You just type in your CPT code, your date of service, Texas, and your locality. I'm saying Austin. You see all these numbers down here? That's where I'm getting all the numbers to plug in. Here's their conversion factor. Here's all their work and gypsies. So you just plug those in. So that's where I get it from. And I'm going to stop sharing that and go back to our presentation. So if you wanted to plug in those numbers and do the long calculation, it is the most accurate, up to the penny there. Some people just want to know the percent over Medicare. So you can do the short calculation. I just want to make a note here that you will not find a list of CPT codes and amounts on our website except for workers' comp specific services. So people call us and go, where's your whole fee guideline with the CPT codes and the amounts? We don't do that. We can tell you using the short calculation, you can take the Medicare fee schedule and multiply it times 217% for those categories I mentioned earlier. So the shortcut is if you're in January, you see Medicare's published their conversion factor. It's this year is $32.3465. So you would take ours divided by theirs, and it comes up with 2.17 or 217%. You would take what Medicare would pay you and multiply times 217%. That comes up with our MAR. So take what Medicare is going to pay you, multiply times 217%. So our conversion factor divided by theirs is going to give you the percent. So taking that same example, 99214, our conversion factor divided by theirs times the Medicare amount, and you come up with $276.54. If you're doing the short calculation, it could be off for a few cents here and there, but if you choose to do the short way, just know it's approximate. It gets close. Now, so that's the majority of CPT codes on the professional side. You would use that short calculation or the long one if you would like. I'm going to get into some details here, and that is reimbursement for PAs and nurse practitioners. We know that a lot of our PAs and nurse practitioners are taking care of our injured employees because I wanted to cover this to make sure y'all understand. This is again for non-network reimbursement of PAs and APR or nurse practitioners. 203 covers the reimbursement for these, and they can practice in our system and receive reimbursement. But also know that in the statute 413, it has a little loop to 1451.104 in the insurance code, and it says we may not discriminate in an amount or method of payment or reimbursement for PAs and NPs and some other healthcare providers too. But know that 203 applies and 413.011. And how that works is 1451.104 says that the statute allows for a different amount of payment or reimbursement for APRNs, nurse first assistants, licensed surgical assistant, or PAs. They'll allow for a different reimbursement for them if the methodology used to compute calculate the amount is the same methodology used to compute the amount or payment or reimbursement for a doctor or a physician. So I know that sounds complicated, but just know that it applies because Medicare has this lesser of clause that says in their Medicare claims processing manual for PAs and a nurse or non-physician practitioners, it says that it's either paid at 80% of the lesser of the actual charge or 85% of the physician's fee schedule. So this conflicts with 1451 because you have to use the same methodology that a physician is using. So 85% of what a physician is paid does not conflict. So basically, our non-physician practitioners are going to get the 85%. They're not going to use the lesser of clause because that conflicts with 1451. So for PAs that are doing assisted surgery, you know, Medicare does a little bit something different there. They have an 80% of the lesser of the actual charge or 85% of what a physician is paid. And what a physician is paid for an assisted surgery is 16% of the surgical payment amount. And PAs receive 85% of that 16%. Also, you're going to be using the AS modifier. So I think it just comes down to we don't ever use the 80% of the lesser of the actual charge for our non-physician practitioners because it conflicts with the insurance code. What doesn't is the 85% of what a doctor would be paid. So this is what it says here on this slide. Just know, I think everybody has a good understanding of that. We don't get too many questions, but if there is a dispute, you're going to see this language pop up on your medical fee dispute decision. So just taking a 99213 for a PA or NP in 2025 in Austin, Texas with no contract, our conversion factor is $70. The Medicare conversion factor is the 32, and the short calculation is going to come up with 217%. And then using Austin as a locality, $90.68, you're going to get 85% of that. So there are the short calculations for a PA or NP. Let's talk about other categories now. In the 134.203, there's a section that talks about your alphanumeric type charges, your A, E, J, K, and L type HCPCS codes. It has a clause in there that says you're going to get 125% of the Medicare's durable medical equipment, prosthetics, orthotics, and supplies, the DMEPOS fee schedule. If Medicare has a value for it, we're going to pay you 1.25 of that amount. So you can multiply times 125%, finding the DMEPOS fee schedule. Novitas does not administer the DMEPOS fee schedule. You have to go to another Medicare administrative contractor for that. But you can also find it on the cms.gov website for your location. Find out if Medicare values your A code or your E, J, K, or L code. If they do, you take that amount and multiply times 125%. Now, if the code has no published Medicare rate, then it's 125% of the Texas Medicaid fee schedule. And if neither Medicare nor Medicaid have a rate, then you're going to apply the 134.1 medical reimbursement, which is fair and reasonable. So just know if you're billing A, E, J, K, and L, it's a step down. Medicare first, not Medicare, Medicaid, if not Medicaid, then it's fair and reasonable. Let's talk about fair and reasonable. So you could be out there trying to bill something that doesn't have a value. I found one, it's 21899. Usually a lot of the 99 CPT codes don't have a value. So then you're going to face, well, what are you going to get paid and how do you value that? What is the reimbursement for something that doesn't have a value? So I just took 21899 and we'll walk through it. So again, section 134.203F. This is where it says for those products or services which no relative value unit has been assigned by Medicare, use Texas Medicaid, or we don't give it a rate, then you're going to look at fair and reasonable. So let's look closer at 21899. Oh, and a note there. Make sure you're using the most specific CPT code for the service you're providing. Also, if Medicare says use this CPT code instead of this one, we want you to do what Medicare asks you to do. So if you're choosing a code that's more general to see what you might get paid, but Medicare says use the other one, you're going to have problems getting paid. So make sure you're following what Medicare says to use for that service. So I wanted to say that it's important because the 99 codes aren't very specific. So let's just take that one. You're going to check to see if that code has a value. The Novitas website, I took you to it earlier. You're going to go to that same fee schedule. Here's the exact URL for that. And I looked up 21899 for Austin, Texas, and it has a 0 in the participating provider amount. So you know Medicare is not valuing it. The next step is Medicaid. Does Medicaid, Texas Medicaid, because each state has their own Medicaid fee schedule, does Texas Medicaid value this service? Our Texas MAC, if you will, it's not really a MAC, but it's a contractor that administers the Medicaid, processes medical bills for Texas Medicaid, is Texas Medicaid Health Partners, and it's TMHP. For the exact URL, there it is on your web page. That's where you're going to go to try to find the Medicaid fee schedule. And you're going to look up the static fee schedule under the resources tab on the tmhp.com website. And in this type, for this example, it's a physician charge. So you would select the fee schedule for physicians. And I just pulled up, it's generally an Excel spreadsheet. 21889, it has no value by Medicaid either. So you've checked Medicare, you've checked Medicaid. Does the division value 21899? No, we don't have a rule that values 21899. So you've done your 3 steps, and the 4th step is to apply 134.1. This is basically the fair and reasonable rule. This is your default if nothing else specifies a value there. We want you to understand fair and reasonable reimbursement, because if you're asking a carrier for X amount for that service, you need to understand what X amount needs to be based on. So you've already gone through the check, do you have a contract? Is it in the fee guideline? Use fair and reasonable. That's what 134.1 will tell you, generally speaking. If you're down to fair and reasonable, you need to follow the criteria that I've talked about previously in 413.011. Basically, you need to ensure that similar procedures to the one you're provided in similar circumstances, receive similar reimbursement. So you're going to have to use other examples of what are similar services, similar situation to justify the amount you're asking for. And it can be based on nationally recognized published studies, maybe previous medical fee dispute decisions. You can always search there for previous decisions or values assigned to services involving similar work or resource commitment. So, what are other payers paying? Put together your position statement. Your best practice is to develop a rationale or method. Just saying, I want to be paid 100% of my charges is probably not going to fly unless you have a good rationale or position statement behind it. Especially if you don't like the amount they pay the first time, you're asking for reconsideration, have that position statement ready, because even after reconsideration, if you want to go into medical fee dispute resolution for non-network disputes, you need to have that position statement. Coming into MFDR, you have the burden of proof to justify the amount you're asking for is meeting the statute 413.011 and what 134.1 says. If you know your service doesn't have a value, I would be asking for negotiating a rate up front. That's the best, because once you've provided that service, then you're left with reconsideration and then MFDR. You're taking some chances. So that's the best option, is to talk about that with the carrier up front. Try to get an agreement up front. If not, you've billed your code that has no value by Medicare or Medicaid, and you're asking for reconsideration. Try to negotiate then, so you don't have to come to MFDR. Now, if during reconsideration, they still don't agree with the amount you're asking for, you can come to dispute resolution if it's not a network contract, if it's non-network. So just have your position statement coming in and just saying, I want X. You probably will not prevail in medical fee dispute resolution. So both the carrier and the requester have to have a rationale for what they paid meets the statute and the rule. So some resources for your medical fee guideline. We have a frequently asked questions document on our website under M for medical fee guideline. You will see all the fee guidelines listed, and you will see an FAQ. In that FAQ is a lot of great information. We talk about the combination of HIPSAs or PSAs and DWC incentive payments when they conflict or they overlap. There's a FAQ for that. There is more information about durable medical equipment fees, the MEI, the MAR for pathology and laboratory services. They have some calculation in there. So they have calculations for anesthesia and other topics in the frequently asked questions. So go to M for medical fee guideline, open that page, go past the fee guidelines and go to the FAQs. That's where you can find a lot of the information you're seeking. Also, the websites I've been talking about. The main website for Medicare is Center for Medicare and Medicaid Services. That's cms.gov. The Medicare Physician Fee Schedule is at the Novitas website. You can also find it on the CMS website for your location. So either the mother website, which is CMS, or the individual Medicare Administrative Contractor, or MAC, for Texas is Novitas. The Medicaid fee schedules, MHP, the specific URL for finding the static fee schedule is there for you to look up. So that's the medical fee guideline. There is a lot to that rule 134.203. Just make sure you look through it, and then you can always call us if you have further questions. Now, there are fee guidelines after 203, and they go from 209 to 230. So 134.209 to 134.230. A lot of information there. Those are the workers' comp specific services. We usually give you descriptions of those services that are unique to workers' comp. We actually give you CPT codes. We give you modifiers that apply, and we'll give you reimbursement amounts. So if you're looking past 203, you will see CPT codes with amounts in these fee guidelines. So the applicability section is in 209. So if you read that, that's sort of a general overarching rule for all of those workers' comp specifics. And it states that these rules do not apply to those services covered by 203, 134.203, prescription drugs or medicine, hospital services or facility services, those services provided through a network, and other miscellaneous exceptions. In the workers' comp specific services, you will find 134.210, which includes coding, billing, reporting for specific services, and which of those services in the workers' comp specific will include the DWC incentive payment and the list of our modifiers. So that's 210. 209 is the applicability. 210 gives you modifiers and other information about how to apply the workers' comp specific services. We have a specific fee guideline for home health services. If you are a licensed home health agency, we are going to reimburse 125% of the Texas Medicaid fee schedule for home health agencies. That's for licensed home health agencies. If you don't have a contract, again, if you have a contract, the contract's going to supersede. Case management services we mentioned earlier. This rule exists because we want treating doctors and referral doctors to get paid for case management activities. So we think it's important that the treating doctor and referral doctor work with other entities to try to provide the best care, and to help the injured employee return to work as soon as it's medically safe and possible and appropriate. Because the longer they're off work, the sicker they can get and the less likely they're going to return to work. So this is really important to us. And this rule applies to all treating doctor and referral healthcare providers. It gives you CPT codes. Remember, the CPT codes have been deleted by AMA, but we keep them alive by naming them in this rule, the modifiers and the reimbursement amounts. So case management services include team conferences, telephone calls with outside interdisciplinary teams. You'll see the codes listed there, the 99361. They were deleted in 2007, but again, we keep them alive. If you're going to build these codes, your documentation needs to support the level of service and meet the description. The description of these codes that are not in your CPT code book anymore, they are listed in the medical fee guideline frequently asked question number 7. We have the actual definition for each one of those CPT codes. I would take a look and see if your doctor is performing any of that so you can charge for it. 99362 is an example. You're going to use the W1 modifier for treating doctor billing this, and this is for a medical conference by a physician with an interdisciplinary team of representatives, community agencies, to coordinate the activities of your injured employee and the patient's not there. That's approximately 60 minutes. Your documentation, anytime you bill a timed code, you need to have a time in and time out to make sure your documentation supports that. It's $198 for the treating doctor and for that hour, and $50 for any contributing healthcare provider. So take a look at those codes. There might be some that your doctor's doing and you're not billing for. Another workers' comp specific fee schedule our fee guideline is 134.225, functional capacity evaluations. In there is a limit. We say there's only 3 functional capacity evaluations allowed per injury. DWC order, unless it's DWC ordered FCEs, they don't count towards the 3. So if you're trying to give an FCE service to your injured employee, you need to make sure you're not the 4th, because 4th won't be reimbursed unless we ordered you to do that. So up to 3 for each patient. We're not saying you have to do 3 on each patient. It's just up to 3. That's a 97750 with a modifier FC. So, and it has more information about how to build the units. The reimbursement can be found for 97750 and 134.203. That's actually said in this rule. Documentation is required and outlined in the rule so that you're actually doing an FCE. So 134.225, if you're billing for FCEs, all the details are found in there, but only 3 per injury unless we ordered some. Work hardening and work conditioning, 134.230 are our return to work rehab programs. Again, we value returning injured employees to work. We're going to pay you work hardening and work conditioning amounts that are found in 230, chronic pain management programs, and outpatient medical rehab programs. Accreditation by CARF is recommended, but not required. But if you want to know the standards in which, if you're being questioned, look at the CARF standards for what a chronic pain management program, work hardening, work condition. That's a good thing to know for your, even if you're not accredited by rehab facilities. The Commission for Accreditation on Rehab Facilities, that's CARF. Use the CPT codes and modifiers that are listed in this rule and bill per hour. So if you're billing and your specialty is work conditioning, this is your rule. Now we're going to go over subchapter B for miscellaneous reimbursement. 134.100 is when your treating doctor attends an RME exam. That's only if your doctor and patient decide that's what he or she's going to do. Then you would find your reimbursement there at 134.100. Sometimes the injured employee has travel expenses. That's 134.110. There's also a form under F for forms for injured employee. You can find that. If you're trying to assist an injured employee that's traveled, they can get reimbursed for travel expenses. So medical documentation, that's an important one, 134.120. The initial copy of medical records you're sending to the carrier is not required to reimburse that amount, but subsequent copies, they do have to reimburse. If you're sending one copy to one part of the carrier, they're deemed to have received it in all parts of the carrier, just FYI. The injured employee is entitled to their initial copy of medical documentation without charge, but any subsequent copies the requester needs to pay. The reimbursement amounts for that documentation is found in 134.120. So if you're providing records to the Office of Injured Employee Counsel, we call that OIC. It's a separate state agency that provides ombudsman services to injured employees. Sometimes they may ask you for medical record documentation. There is a rule that says you can get reimbursed by the carrier. So 276.11, and the reimbursement is found in 134.120. If you're providing records to a designated doctor for a designated doctor exam, that's found in 127.10. The treating doctor may be reimbursed for the records sent to the designated doctor by the carrier. So again, the reimbursement amounts are 134.120. Now, there's a special rule about interest for late payments, 134.130. So that is interest that is charged in our system or paid in our system for either late payments from the insurance carrier to you, or if you, healthcare provider, have been asked for a refund and you're late in paying it, you may owe interest also. So if the insurance carrier is paying you on or after the 60th day after they originally received the complete medical bill. Then they start owing interest. So they have 45 days to pay, reduce, or deny. But say they're going on 60 days, they're going to start, if they're going to pay, they're going to owe interest for that also. On the healthcare provider side, you again have been asked, if you've been asked for a refund from the carrier, if you haven't paid that back to the carrier later than the 60th day, you're going to start to accrue interest also, and you'll have to owe that to the insurance carriers. So that's late for late payments. We calculate the interest rate quarterly and we publish it on our website. 134.130 is the rule. Basically, this is how it works. You're going to calculate the interest by taking the rate of interest, multiply the rate of interest by the amount that's due to determine the annual amount. So then you divide by the number of days in a year, 365, to get the daily interest, and then multiply that daily interest amount by the number of days. So if they paid on the 65th day, that's 5 days. You need to multiply the daily interest rate too. Now we have a calculator out there on our website that shows the interest rates, and you can type in the date it was due, the amount that was owed, and the calculator is there in an Excel spreadsheet for you to calculate interest. So if you're interested in that, that's the URL to calculate it yourself. You can also go to our, search and find button and type in interest rate calculator. You can get there. So we're coming to the end. We have covered chapter 134. All the rules in there are about payment, all of chapter 134. We went over specifically professional services in the medical fee guideline, some reimbursement calculations. We talked about if you're asking for something that requires fair and reasonable reimbursement, workers' comp specific services, and then some miscellaneous reimbursement. Now we're at a part where we're going to train your brain. So hopefully you're not too sore from the previous videos. I'm going to pull up a poll. There are going to be 5 questions. Let's see. The first question is, if a Medicare payment policy conflicts with the Texas Labor Code or one of our rules, the Texas regulation prevails. That is true. Most of you got that right. So like incident 2 billing, we don't allow that because if you're licensed, you have to bill under your own license number. Number 2, healthcare providers should bill using the most current CPT or HCPCS codes along with Medicare reporting and coding policy with a few exceptions, and that is true. Yay. Number 3, the non-network professional reimbursement for office visit is the exact same amount as Medicare. That is false. We pay 217% of what Medicare pays, so more than double what Medicare pays. Number 4, best practice is for a healthcare provider to have a rationale for the amount they are seeking for a service that is reimbursed at fair and reasonable. That is true. That is the majority of you got that right. You do have to have a rationale. There is no limit to the number of FCEs that are not ordered by DWC for an injured employee to have. That is false because they can only have 3 unless we order. Little trick question there. If you have questions for us, we have a hotline for healthcare providers, and insurance carriers can use it also. It's Comp Connection at 800-252-7031, option 3, or you can email us at compconnection@tdi.texas.gov. Thank you for joining us today for this video.